Great, thank you. Hello, everyone. My name is Karen Chung. I'm with the Lewin Group, and we're supporting the Medicare and Medicaid Coordination Office and the Centers for Medicare and Medicaid Services to ensure that dually eligible beneficiaries have access to seamless, high-quality health care. Let's go ahead and get started. Next slide, please. This webinar is part of our 2017 Meaningful Member Engagement Series. Today's session will include a 60-minute presentation from 4 experts, followed by a Q&A discussion between you and the presenters. This session is being recorded, as you heard, and a video replay, the slide presentation, as well as the questions and answers will be available on our website at resourcesforintegratedcare.com. You should have also received a link to the program materials earlier this morning from an email, webinars@confortel.net. And if you were to click on that link, you're able to download the slides from our website. Next slide, please. This webinar is presented by the Lewin Group and Community Catalyst and supported through MMCO at CMS. Next slide, please. MMCO is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar. And to learn more about our efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. And I believe we can post that on chat as well. Next slide, please. We have a packed agenda, and I think you'll all take away some key learnings from each of our presenters, including innovative strategies and interventions used by providers working with Medicare, Medicaid beneficiaries, and others with mental health conditions or substance use disorders. Our presenters will also describe their person-centered approach for working with these populations and provide examples from a variety of settings, such as in the hospital, within an ACO, and treatment centers. So at this time, I'd like to introduce our moderator, Rosa Palacios. Rosa is a Consumer Engagement Advisor at the Center for Consumer Engagement in Health Innovation at Community Catalyst. In this role, she develops approaches to engaging individual consumers as well as hospitals and plans. Rosa has experience working with older adults and people with disabilities. Prior to joining Community Catalyst, she was the head of the Department of Health Education and Caregiving Training at Common Health Care Alliance. Rosa, I'll turn it over to you.
Thank you, Karen, and welcome everyone joining us today for our first webinar about meaningful member engagement. As Karen mentioned, I work for the Center for Consumer Engagement in Health Innovation at Community Catalyst. The center is a hub devoted to teaching, learning, and sharing knowledge to bring the consumer voices to the forefront of health innovation. Let's go ahead and walk through the agenda for today's discussion. Next slide, please. Thank you. First, we're going to begin with Commonwealth Care Alliance and their strategies of a patient-centered experience. Then we heard from UPMC for You Health Plan, and we'll discuss innovative strategies of engagement. Next, Trilogy Inc. will focus the conversation around engaging clients in mental health, substance use, and integrated treatment. And last, Camden Coalition of Healthcare Providers will talk about their community-based, multidisciplinary care management for vulnerable populations approach. We will take one last poll before moving on to questions and answers. At this time, I would like to introduce to you our platform for this presentation. Next slide, please. Barbara Herbert is a doctor and a fellow of the American Society of Addiction Medicine. She is also the Medical Director of Addiction Services at Commonwealth Care Alliance. She practices community-based medicine under a demonstration grant that serves Medicare and Medicaid eligible patients. The grant also includes a methadone clinic and an innovative mental health practice. Dr. Herbert received her MD from State University of New York at Stony Brook. She completed a surgical internship at the University of Pennsylvania, an emergency medicine resident at Johns Hopkins Hospital, and was a fellow in social medicine at the Mary Ingraham Bunting Institute at Harvard University. In 2010, she became a fellow of the American Society of Addiction Medicine, and shortly thereafter, a diplomat of the American Board of Addiction Medicine. Dr. Herbst served on a number of policy initiatives for Governor Patrick and several Massachusetts legislators. She sits on the ASAM Quality Improvement Council, the MMS Opioid Task Force, and is current president of the Massachusetts chapter of ASAM. John Lovelace is the president of government programs at UPMC for You Health Plan, a managed care organization that serves medical assistance and Medicare Advantage special needs plans recipients in 40 counties in Pennsylvania. John provides leadership, direction, and administration for the services provided by UPMC for You, which offers coverage to eligible medical assistance recipients through its contract with the Pennsylvania Department of Public Welfare, as well as coverage options for Medicare beneficiaries who are also enrolled in the Pennsylvania Medical Assistance Program. He is the Chief Program Officer at Community Care Behavioral Health Organization, a behavioral health managed care organization that is part of the UPMC Insurance Services Division. John holds graduate degrees in rehabilitation counseling from the State University of New York at Buffalo, as well as in information services from the University of Pittsburgh. Amy Joyner is the Director of Outpatient Recovery Services and Intake at Trilogy, Inc. Trilogy is a not-profit integrated community health center in Chicago. She is a licensed clinical professional counselor and a certified alcohol and drug counselor in Illinois. Ms. Joyner began her career at Trilogy in 2000 as a case manager in the mental health field. In this role, she realized her passion for working with older adults suffering from severe and persistent mental illness and co-occurring substance use disorders. She became a director at Trilogy in May 2014 and is currently focusing her efforts on increasing adult, child, and adolescent outpatient and recovery services throughout the Chicago area. Amy received her MA in Counseling Psychology from Northwestern University and holds a BS in Psychology from Loyola University in Chicago. Bill Nice is a social work coordinator with the Camden Coalition of Healthcare Providers. His primary roles involves working directly with patients who are homeless or are at risk for homelessness by connecting them to local services and community resources. This includes ensuring individuals have an advocate who can assist with navigating the social service system when necessary. Bill has worked in the city of Camden for the past 6 years and is currently a member of the executive board of the Southern New Jersey Continuum of Care. He has a BA in communication from Rowan University and recently graduated with an MS in social work from Rogers University. Now I would like to hand the webinar over to Dr. Barbara Herbert. Dr. Herbert.
Thank you very much, Rosa. Next slide, please. Some of you may be surprised that I used patient-centered experience as opposed to member-centered experience. And I know that many of us move back and forth in that language. So I'm moving back or forth to emphasize that one of the great successes that we've had at Commonwealth Care Alliance, and that I think may be the biggest single key to getting people into care or holding them in care, is seeing them as individuals. And so I adopted this to remind us that each of the people that we're caring for, we have to think of individually and the quality of their experience. I'm going to, next slide, please. I'm going to talk about 5 strategies. Next slide, please. Oh, good. There it is. No, sorry. I'm going to talk about 5 strategies. The first is maintaining asset-based engagement. and I'm going to talk about using modified motivational interview tools that I'm sure are available to many of you and many of you already use. Then I'm going to talk about identifying people at high risk and articulating the risk. So in this part of the talk, I'm going to talk more about the articulation to the individual than the use of the tools to find them. Then my third point, collaboration, is probably the single most important point that we have. And then finally, meeting the affected person where the person is. And then fifth, offering meaningful social support. So next slide. When we talk about maintaining asset-based engagement, probably the single most valuable thing that we have to offer is authenticity to our patients, that they get to really feel that we are truly engaged with them. And because they're difficult patients, I think that it allows us to be able to articulate ways that they're difficult. So obviously we'll want to express empathy through reflective listening, avoid argument and direct confrontation, adjust to the person's resistance rather than opposing it, but be straightforward with how we see and what we see in front of us. Next slide, please. Then when we talk about maintaining asset-based engagement, there are three arenas that we do not always include. The first is the issue of spirituality. For people with addictions, there is often a spiritual or extra-rational deficit that is contributing or is owned by their addiction, and exploring historic or current spirituality. By this I mean raising questions about whether a patient has engagement with traditional religious organizations. Many more of our patients have had strong religious engagement than we know because we often don't ask about it. And for many other of our patients, the experience of their familial spirituality, their grandmother's favorite saint, or their sense of an elder who practiced within a tradition that's not necessarily Christian, but their sense of closeness to that elder, often no longer alive, but to that elder's practice, brings another dimension of hope into our engagement. Then the next piece is that many of our most difficult patients really suffer from loss of purpose or meaning and are really interested in being able to collaborate or produce something of value in the community. That may be a way that we encourage them to join groups or take up extra activities, but the desire to be altruistic can't really be underestimated in the population of the most hopeless and hard to reach. And then finally, we need to search for whatever areas of optimism they experience in their lives, relationships with other people, or specifically with animals. And we've had some success bringing animals into encounters as a way of allowing our members to experience hope again. And then, of course, connection with any creative endeavor. And a history of creativity. Many of our members have had surprising experiences of success with putting up a painting or paintings in a shelter, or even self-publishing poetry. All of these become tools for us to see the whole person and for them to trust us more. Then, of course, the second piece is we need to identify people at high risk And CMS reports of high opioid users, insurance claims data that tell us about extensive emergency department use for pain, and so-called doctor shoppers. We need very much to be able to say to our people how they're seen and how we're finding them. One of the things that I found very useful, this linguistic tip at the bottom of the slide, is not to talk about behavior that puts people at risk for overdose. We know that many people who have overdosed don't see themselves as people who have overdosed, but instead that we talk about bad reactions, opioid safety, or accidental overdose. Next slide, please. And we need to be very open that prescription monitoring programs mean that every time they request opioids, everyone is going to know everywhere they have gotten opioids previously, unless they're in a methadone addiction program, because those opioid treatment programs do not show up on the PMP. Next slide, please. Now, in terms of collaboration, obviously, I doubt that I have to suggest to this audience that we use all human sources we can to try to find people that we're reaching out to. Service providers, but point of contact, but there's another source that we often don't necessarily engage with, and that is family. Many more of our patients have some relationship to family than we expect. This can be a little tricky. We have to assess for the safety of engaging any other family member, particularly when you're thinking about possibility of intimate partner violence or other kinds of family toxicity. But also, many of our patients have networks of kinfolk or other people who are engaged in their lives who will be helpful to us as we try to get people into care and hold them in care. Then, next slide, please. When we talk about meeting the affected person where the person is, the first way we're talking about that, and I believe that this sculpture of two homeless people kind of captures both my kinfolk idea and the notion of us going out to where people are, is that mobile teams that can meet people where they actually are living are invaluable. But meeting the affected person where they are also means thinking about trauma-informed care, thinking about what's going on with them culturally, and acknowledging both the social stigma and the right to refuse care, and coming back to people who have refused care, still acknowledging their right to refuse care. So I'm just going to talk about two examples of from this slide. The first is obvious to me because it's geographic. Next slide, please. But if we draw on principles of trauma-informed care, and in my experience, probably more than 90% of the women I see have had some experience of trauma. If you are opioid addicted and female, even if you didn't have an experience of trauma before you became opioid addicted, it's very difficult for you to have carried on without having some experience of trauma. So what does it mean for us to think about trauma-informed care? And here I want to say, as our chief of psychiatry says here often, thinking about trauma-informed care is a lens that gives us a greater understanding, tolerance, and interest in the context of a person's life. Trauma-informed care does not mean that we don't hold people accountable, because when we fail to hold our members accountable, we fail to believe they can change. But it means that some of the most frustrating and irritating aspects of our encounters can be processed differently by us. So I'm only going to talk about the 5 guiding principles that SAMHSA has put out for us, first of which is safety. At the beginning of anybody dealing with their trauma is that they need to feel that they have some safe space to do it. But it also means safety for us as providers, that we don't take risks in circumstances that are unsafe. The next is what I called authenticity at the beginning of this brief talk, and that is the trustworthiness and transparency that people can feel from us. And that's part of why we need to be able to say to someone, you're going to be characterized as a doctor shopper because this is what the PMP does. And that's where we're starting, because this is what's happening in this time. The next principles are peer support. This is one of the primary ways that we encourage people to use 12-step meetings, for example, by saying that our patients deserve the support of other people who've been through them. Collaboration. Nobody can do this by themselves, neither our members nor our workers. And then trying to enhance empowerment and voice for our patients. And then finally, in the same way, holding on to a lens that includes looking at cultural, historical, and gender issues as they play out in our patients' lives. Next slide, please. And then, of course, this culturogram, which comes from SAMHSA's tip 59, suggests the range of ways to think about context. Next slide, please. Obviously, one of the best ways for us to be able to engage with people, if we're going to be trustworthy and transparent, is to offer meaningful resources. Most often, this is through our outreach staff, which includes outreach workers, recovery coaches, case coordinators, which I know is the largest number of people listening, and care partners. And then next slide, please. Among those meaningful resources, I'm listing examples of services that we can offer, but also each time we engage across a service gives us a chance to bring the same kinds of member-centered respect. When we help someone find a food pantry or go with them because they have difficulty transporting the food back to their house, and we treat them with respect and we engage people in the food pantry with respect, we help to break some of the stigma that makes it so hard for people to come and see us. Finally, next slide, please. We have to take care of one another. The patients we're trying to reach out to have been highly stigmatized and often react to any kindness with bitterness and anger. We know that actually getting people into treatment works. And we know that hopelessness is our worst enemy in this. But we have to also remember that we take care of one another. That's the other most critical arena of collaboration. None of us does this for no reason. So all of us carry vulnerabilities that can become enhanced by our engagement with difficult patients, complex members, unless we care particularly for ourselves. Thank you very much for listening, and now I'm going to turn it over to John.
Thank you. Thank you, Barbara. That was a wonderful launching pad for, I think, what the rest of us are going to talk about in terms of setting the ground for us. So I very much appreciate your effort in this helping us get the tone to this. So a couple of common themes, I think, that you've heard from Barbara. Treating people with respect, the importance of peers, and the importance of providing services that recipients see as tangibly beneficial to them, like concrete services as well as sort of therapeutic and helpful services. I'm going to talk about a couple of interventions that UPMC Health Plan has implemented for high-risk consumers. These are really, it's not entirely limited to people who are Medicaid recipients and special needs duals, but that's the majority of recipients are indeed either chronically ill Medicaid recipients or people who are dually eligible with some significant health and life challenges. If I can move up a slide, please. Just a bit about UPMC as a whole. We are an integrated delivery system based in Pittsburgh, as you might have guessed. We're about a $13 billion business. We operate hospitals. We operate a whole continuum of clinical care, about 4,000 or so employed physicians. We have a large insurance division, large regional insurance division. We're about 3 million members in total, primarily in Pennsylvania. Our Medicaid line of business is about 410,000 folks, and our Medicare business is about 160,000, of whom about a fifth are dually eligible. So just to get a little background of who we are. So part of this integration on the clinical and health plan side gives us, I think, a unique perspective in terms of integration of care and services. We are not a Kaiser, so the health plan has many other network members other than UPMC, and UPMC, the health system, has significant numbers of other payers in addition to the health plan. So it's an open network model, but a bit of what most of what drives us is this integrated delivery system, whether it's with ourselves or with other healthcare partners. If I can move up a slide, please. We're going to talk this afternoon in my few minutes here about the population of people that we're trying to reach, the challenges of those folks, and then some, as Barbara's laid out, some strategies around identifying and engaging people with services, and a couple of examples of some concrete things we have done in services with the outcomes. And one more slide, please. So this is a description of the special needs population. It would look no different really if we're looking at the age-blind disabled population in Medicaid particularly. This is just a characteristic population. More than a third of the people have serious mental illness. That is not how they got into the program necessarily. They have many other comorbidities. The top DRG for admissions you can see is psychosis. There are people, in large part because A, it's a lot of people, is a third of the population, and also because the readmission rates are pretty high with these folks. And then you can see here a list of complications, of the medical complications that are associated with this. There's a significant number of people also who have long-standing substance use disorder problems. The overlap of the serious mental illness and the substance use disorder, as I'm sure your experience would indicate as well, is pretty profound. Probably overall, about 80% of our enrollees, who are not the non-seniors who are enrollees, have either a serious mental illness or substance use disorder. Most people have both. Our enrollment is about 62% non-seniors and 38% seniors in this special needs population. So everyone is low income. 2/3 of the people have disabilities. A third of the people are aged. And of course, some of those folks have disabilities as well. And the mental illness is pretty evenly spread among the population. Another slide, please. The challenge, as Barbara suggested, is to think about what is it that engages people. The idea of many of these folks, I think as you heard earlier, do not particularly see themselves as having this is their primary problem. So the outreach touch is really, in our experience, more effective when it is focused on things that are important to the person rather than things that are important to us. And at some point, we hope those things converge, but they may not. So we're looking for hooks, if you will, that have a tangible and identifiable benefit from the person's point of view. That's often something like, I need help with my gas bill, not I need help with my diabetes. That diabetes might come later. It's related to the person's goals. Everyone has goals. They may not be the goals you would have, but people have, even in the worst of their times, may have goals related to their families or their children or their jobs or their partners or a variety of other social issues. And things that are really fairly quick turn and impact. So for many people, probably most people, the idea of slowing the progression of one's diabetes is a very, very long-term goal, and it doesn't have enough quick feedback to make it better. So finding things that both have long-term and short-term impacts, particularly so I can see that if I, the consumer, have made an effort, that I get some payback for it. So it might be my gas is turned on, or it might be I fill both my prescriptions. So those kinds of, the general themes of engaging folks are really on these three areas. Another slide, please. So we have used, as other people do as well, analytic techniques to identify priorities of people. It's fed by a variety of data information into one large data warehouse that the health plan operates. They include the ADT feed you see at the bottom left of your screen is a daily feed from our hospitals around admissions, discharges, and transfers. It's just electronic. It goes into a warehouse. No one sits and reads the paper. Luckily, we don't have to spend much time standing by the fax machine, waiting for pieces of paper to arrive. This happens sort of in real time as the patient's being discharged. The results are being fed every day to the health plan. There are issues around health. There's some data we get from consumers directly. People's comments on their health risk assessments, comments from providers, comments from case managers, all of which feed into sort of predictive models around who is in trouble now, who is likely to be in trouble later, what are the signs of impending readmissions, for example. And then we have a whole series of these. Look at the right hand of the slide related to relatively real-time data we get from, not for everybody, for some people who are willing, from remote monitoring and home-based systems, from wearable things, from technology, from cell phone text messages, other ways that are more spontaneous, if you will. Sort of fed into the health economics review team, who helps us to prioritize folks, not only in terms of who is high need, but also who is more or less likely to be reachable and who's more or less likely to be impactable. There are plenty of people who have high risk who are not people you can really help to do much with. Another slide, please. And there are plenty of people, of course, with whom you can. One of our interventions is the development of community-based teams. Like many health plans 15 years ago, we were primarily telephonic. We're apparently slow learners after many years of calling and not reaching people or reaching messages and not hearing back. We still do some telephonic care management. There are people for whom that is useful. But in this group of populations is much more focused on, I think as you've heard a bit from Barbara, about let's go see people where they are. So about 5 years ago, we moved into the development of community-based teams. These are currently teams of combinations of nurses, social workers, and community health workers. Community health workers being non-licensed people, mostly people with lived experience, who with substance use disorders, serious mental illness, or disability, who work in the field and reach the highest risk folks. As you can see here, we're currently seeing about 500 people. So they're pretty high caseloads. These are temporary relationships for most people. We're trying to reach people, assess the issues they're trying to deal with, try to reconnect them to services, and then help them be more to move forward. So as you can see, our engagement rate is better than our phone engagement rates are probably around 30% of the people we try to call, we reach. So in this case, we reach about 71% of people, and we engage about 2/3 of the people we reach. So about half the people we're trying to find and reach we actually engage with. Engage in this sense meaning we have a conversation. You can see on the right side of the slide the kind of efforts we work on. People generally, these are folks largely who are engaged initially while they're in a hospital. Then we do follow up with the home, medication reconciliations, care plans, and so forth. If we could go to another slide, please. This is just a brief picture of the satisfaction results of this service. We have some nice anecdotal improvements around people's connection to services. Time 1 on this slide, the horizontal axis is initiation, and time 2 is about 3 months into the process. So this is just really shows you that as people participate in this process, their satisfaction continues to increase. Not everybody is perfectly happy, of course, but it's a very nice trend up toward the more people are engaged, the more satisfied they are with what they're getting from us. That has to do because it has to do with concrete results. If I could move up another slide, please. But most people start on opioid drugs through prescriptions. That is the most common form in which people begin to interact with the system. That's, in our experience, is very similar to that. They get that sometimes it's for the patient themselves. Sometimes the prescription is for someone else. The person takes it. Sometimes they buy it. So it could be, your own private market. You'll see on the graph kind of how that distribution tends to work out. But as in most cases, particularly as the opioid management services become more sophisticated and the supply of that is reduced, it does, of course, push people more toward illicit drugs such as heroin and combinations of heroin that are so fatal. To address this issue, if we can move up a slide, please. I hope you're seeing a slide that says, what is HEDDS Up? HEDDS Up is a UPMC clinical management program which really focuses on trying to find people who are high emergency department users who are, as Barbara talked about earlier, who are doctor shopping, or that's what it appears they're doing. It doesn't mean they're necessarily criminals. These are people who may be doctor shopping because they have unremitting pain. It may be because they have addiction disorders. It may be both. It may be chronic anxieties from people with COPD, for example, who are struggle this summer with breathing, who get panic and go to the ER. There's a whole variety of issues, but this is focused on people who we think have addiction disorders. The goals of the program to engage people, for those who are, this is not something you do for people who are currently resistant to treatment. This is more of people who are maybe having trouble with pain management. We connect people with care managers, more effective use with more effective primary care connections with folks, better care coordination around things like chronic pain, and has some very positive goals around trying to reduce ED visits and unwarranted costs, as well as reducing, as you'll see on the slides, such as radiation exposure. We've had people who've had as many as 40 CT scans of the belly a year because every time they go to the hospital with belly pain, they go to a different place and they start over again and do another CT scan. So some direct consequences here and some kind of secondary consequences. We have about, as you move on the slide, please, you should be seeing a slide that says reaching difficult to reach members. We have about a 20% success rate. That's something we certainly want to continue to improve. Outreach is both with providers and with consumers. Because of the, I think, back at Barbara's points earlier, because of the acceptance process of looking at this engagement, we do have some proactive effort from consumers who do want to have help linking themselves into effective treatment. And there are many more treatment options than there were even probably 10 years ago. If you look up on the next slide, you'll just see some utilization trends in terms of comparing the utilization of services in the ED for people before and after the service. So the the vertical axis of the slide are visits, and the horizontal axis, of course, is time. On the CT scan, the vertical axis is incidence of CT scans, and again, the horizontal axis is time. And you can see on the lower graph across the bottom, continuing decreases of inpatient admissions for people who are engaged in the process. So things you'd want to be seeing happening. Second intervention is a pregnancy recovery center. It's just an example. This has gone well enough that the state of Pennsylvania, has encouraged people to build these services in a variety of other settings in maternity hospitals across the state. Basically, a maternal care management program for women who are addicted to opioids, managed with Subutex, and care management and ongoing behavioral health treatment. And lastly, speak very briefly about peer Navigator program. Barbara also talked about peers as important in this process. The goal of this process is to engage people more effectively when they're in the hospital for a non-SUD related or SMI related issue. So someone's in the hospital having fallen down the stairs, perhaps they were drunk, or from an auto accident. The peers are trained people who have lived experience, who are in recovery themselves. There's one to a hospital. They're consulted by the attending physicians when that's appropriate to consult with the patient, with the patient's families, or with the staff. The idea, there's some really lovely stories of engaging people because they have more time than the medical staff does typically to sit with a patient, kind of talk about their own experience, help people identify their goals, and help them get into treatment. If you look on the last slide of mine, which is should say UPMC analysis, I think. I'm not sure where we are in the slide picture here. It is, you'll just see, of course, the sort of impact of this rather small-scale project on people at 3 hospitals. These are 3 UPMC hospitals in the greater Pittsburgh area, and you'll see the number of people touched and discharges of visits. So with that, I think I'll wrap up and turn this over to Amy.
Thank you, John. I appreciate it. Next slide, please. Okay, so Trilogy's mission and vision. Trilogy is a trauma-informed community health center serving adults across the Chicagoland area. Our mission is to support people in their recovery from mental illness by helping them discover and reclaim their capabilities, life direction, and well-being. Next slide, please. You should be seeing a slide just on basic client demographics. So in the last year, Trilogy served more than 2,000 adults with mental illness and mental illness with co-occurring substance use disorder. again in the Chicagoland area, so all of Chicago and then a couple of the northern suburbs, Evanston and Skokie. About 60% of our current client population are male, 40% are female. Majority of our clients have a high school degree or some college. Most of them are between the ages of 36 and 65. 99% of our current clients, and this is pretty typical for Trilogy clients, are well below the federal poverty level. Average annual income is less than $6,500. Our current clients all have either some sort of Medicaid, Medicaid managed care plan, or dual. So we have Medicaid, Medicare plans. Right now, Illinois has 5 different Medicaid, Medicare plans, and Trilogy accepts all of those. At intake, about 18% of our clients are homeless. About 40% require linkage to medical care, and 75% require linkage to psychiatric care. Next slide, please. So Trilogy receives referrals from a lot of different places. This just kind of has a partial list on this slide of different places right now. We also get a lot of self-referrals through word of mouth. I'm going to talk a little bit later about our open access intake. We tend to get more and more people just through word of mouth, knowing that they're able to come in and get seen that same day. Next slide. So these are some of the services that we provide at Trilogy. So we have pretty much wraparound services. We have many different outreach teams, which I'll talk about a little bit later in this presentation. We also have Latina services, a full array of outpatient services, supported employment, housing, residential, integrated health care, Williams and Colbert I'll talk about later, and then we also have occupational therapy. Basically for Trilogy clients, what we aim for is to be a one-stop shop. On our north side is our main location. It's the one that's been there since 1971. We have the full array of services. So depending on what the client's goals are, what they're needing, what they're wanting, they can access all of these different services, plus some additional ancillary services, which we'll talk about in a little bit. Next slide, please. So as I mentioned a couple slides ago about our intake services, so a couple years ago, as I think probably many other organizations and places have experienced, and kind of care coordinators the same thing, to try to get a client in for an intake appointment was all kind of done by phone. There'd be a phone screening, maybe someone would call you back, and then maybe it would be weeks later that that client would get their first appointment to access services. We had probably about a 50% show rate, which is pretty typical for intake departments. So, across the nation through help from SAMHSA and national councils, different trainings, we came across open access. What it is it basically has the ability to offer same-day intake. So right now, since about the summer of 2015, at our main location, we have open access intake availability Monday through Friday, 9 a.m. to 3 p.m. So if an individual presents during any of those times, 9 to 3, they will get greeted by an administrative assistant who will kind of check their insurance, and then they will actually get seen by a clinician who will begin their intake and start their assessment, and then they will have a follow-up appointment. Throughout this process, we've seen over 100 individuals pass through our intake every single month. Obviously, this gets rid of the no-show rate as well, because they just show up. This really kind of quickly got moving once hospitals, other organizations found out, managed care companies found out that they know that they could just send their client and that they would get seen the same day. And as long as they had some version of Medicaid, Medicare, we'd be able to open them to services and get them linked to one of our teams. Next slide, please. Our integrated healthcare, so that started back in 2010. We had a SAMHSA grant, and we partnered with Heartland Health Center to provide wraparound psychiatry primary care services. Our main clinic location is also on the north side, although we do have a clinic on our west side, and we're looking to expand that onto the northwest sides as well. So in that clinic, you've got psychiatrists working together with the medical providers, doctors, APNs, we've got nursing students. We're able to do lab services there as well. And most recently, we opened up a pharmacy right there as well at the north side location. So it makes it so much easier for our clients to kind of access all of those services at the same place. And the collaboration and the coordination between all their providers is much more seamless than it ever was before. Next slide, please. One of the things that also happened, and some of you may or may not be from Illinois, is that the state of Illinois was sued, and through a settlement with this class action lawsuit, we began the Williams and Colbert consent decree program. What that is that the state of Illinois was sued for housing adults with severe and chronic mental illness in something that's similar to a nursing home setting. And what the ADA kind of said was that most of these adults could be living in the community on their own with the right support. And so the state of Illinois settled, and because of this, places like Trilogy were brought in to kind of partner to provide these transition services to these adults to get them in their own apartments in the community, and then link them with services at that same agency to provide the services that they need and that they want. Next slide, please. Many of these clients who we've moved out of the nursing homes into their own apartments end up needing Assertive community team, which is ACT services. ACT services are available 7 days a week, 24 hours. They have on-call services. They can always get in touch with the staff member as needed. Also, this is an evidence-based practice, so each ACT team at Trilogy has a nurse on the team, has a psychiatrist associated with it, an employment specialist, a certified alcohol and drug counselor, a team leader, a peer specialist, and at least one recovery counselor. Right now, we have 8 ACT teams across the Chicagoland area, and we'll soon be adding a 9th team as we're expanding into the northwest side of Chicago. Next slide, please. For some of these clients and other clients that just come in through open access, if they may not need that high level of care, which is the ACT team model, for those clients we also offer community support teams, otherwise known as CST. This is also a team model. The difference is that it's limited to 8 staff. So you have 1 team leader, 1 peer specialist, and 6 recovery counselors. There's also 24-hour on-call, but staff are generally available 5 days a week, so Monday through Friday, not really on the weekends. And different from ACT, there's not kind of that complete wraparound service within the team. So CST teams utilize other ancillary programs to provide these clients with the services that they're wanting, like supported employment, dual disorder treatment, therapy groups, etc. And like ACT, we have many CST teams. We have 7 right now and are about to again add an 8th team to expand into the northwest side. Next slide, please. So I mentioned supported employment. I think this is just one of those, kind of amazing evidence-based practices that Trilogy adopted a few years ago and has received a lot of state and national awards and recognition. So it follows the IPS, or Individual Placement Services, fidelity model. Many of our clients, that is kind of what they're most wanting. They're wanting to work. They're wanting to get a job. They're wanting to have that meeting day to day, just as anyone else does. All of our clients, no matter what level of care, team, or program, have access to supported employment. The supported employment specialists are integrated throughout all of the teams, so they go to the different team meetings and are part of that team, but they're specializing obviously in helping clients find and access jobs that they're wanting. So there's not any hoops or hurdles for those clients to go through in order to get a job. You kind of go, you want a job, we're going to help you find a job. Not any of, well, you need to do this, or after you do this kind of mentality. Next slide, please. So some other ancillary services that we provide are wellness services. Right now we have our In Shape program, which is comprised of 3 mental health professionals, and they're also personal trainers. And we have a variety of other wellness services that the integrated health clinic staff and recovery counselors collaboratively facilitate, whether that be within groups or individually. As John mentioned, we also have peer staff. We have a peer-led drop-in center at our north side location that's open 365 days a year, and we also offer the in-home peer recovery support services. I think I skipped this slide. Can you skip again? There should be on the additional partnership slide. Thank you. One of the ways that we found very useful is that Trilogy is very adaptable and very flexible and is often at a forefront of new initiatives in Illinois and has become kind of the go-to for outside organizations, the state, the city, different partnerships, collaboration to ensure implementation of these programs. These are just a few. The Diversion pilot program recently began, and that the aim of that is for us to go in and work with social workers in the ER and kind of divert those clients from ending up in a nursing home setting back into the community with the right supports from Trilogy. And then next slide, which is my last slide. Training partnerships, I think also with this is just trying to continue to build on our staff training. We bring in a bunch of different outside collaborators to help with that. And then lastly, we also provide community training through mental health first aid. We've been partnering with Presence Health, which is a huge hospital in Chicago, and have been offering those trainings and have recently trained over about 200 community members in 2016. And I think that's it for me. Thank you so much. And next up is Bill.
Thanks, Amy. I appreciate it. So a lot of the information I'll be mentioning has been already referenced in a lot of other people's presentations as well. So the Camden Coalition of Healthcare Providers is a nonprofit organization working in the city of Camden to improve health and reduce costs. We are a citywide coalition of hospitals, primary care providers, and community representatives that collaborate to deliver better health care to our most vulnerable citizens. And we believe if we can improve care and reduce health care costs here in Camden, that it can be done for everyone, everywhere in America. So we innovate and test healthcare delivery models to improve patient outcomes and reduce the cost of their care using data-driven, human-centered practices. We draw on the experiences of our clinical teams and patients, and coalition staff also work to transform healthcare cost and delivery at the policy level. Since 2002, we've been demonstrating that human-centered, coordinated care combined with smart use of data can improve patients' quality of care and reduce expensive, ineffective inpatient stays and emergency room visits, which is better for everyone. Next slide, please. So the Camden Coalition members share information through the Camden Health Information Exchange. With relevant real-time data, our cross-disciplinary care teams connect quickly with people who have high rates of hospitalization and emergency room use and help them address their complex needs. Our care teams include registered nurses, licensed practical nurses, community health workers, social workers, and a clinical psychologist who assists the team as a behavioral health consultant. But all of our engagements really center around the idea that therapeutic relationships start with a framework of acceptance. And to build trust and collaboration, we view those around us with unconditional positive regard. We're practicing unconditional positive regards means that we're accepting and respecting others as they are without judgment or evaluation. And to continue to build that therapeutic relationship, we need to show empathy. We need the ability to understand and share the feelings of another by remembering a time when we felt similar emotions. Next slide, please. To promote safety while also recognizing patients' self-determination, we use harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences of various human behaviors, legal and illegal, but especially those associated with drug use. The defining features are the focus on the prevention of harm rather than on the prevention of drug use or harmful behavior itself. And the focus is on people who enact the behaviors. And to help the person identify their own personal motivation, we use motivational interviewing as a conversational treatment that engages a patient's motivation to change based on his or her own needs and wants rather than a provider's goals or our own care team goals. Next slide, please. So we also use a trauma-informed care approach to patient engagements. This framework for care realizes the prevalence of trauma in a population. It recognizes the presence of trauma symptoms in an individual, acknowledges the role trauma has played in the patient's life, and seeks to avoid re-traumatization. We also discuss adverse childhood events, or ACEs. These toxic stress events like abuse and neglect, or maybe witnessing experiences such as crime, parental conflict, mental illness, and substance abuse have profound consequences on one's health, behavior, and action. So each event increases the level of stress, impeding their healthy development and resilience. Remembering that something as simple as a touch or closing a door can trigger somebody's thought of a previous event. Re-traumatizing the patient is very important when we're working with our patients. So we take these factors into consideration to provide a holistic biopsychosocial centered approach that looks at the person as a whole and meets them where they are. We then use an engagement framework called COACH to move through our intervention. Next slide, please. So COACH is simply an acronym that represents how we interact with patients. It's about taking people from where they are to where they want to be. Each letter stands for a different philosophy or a tangible tool that our teams have used in the field. We basically start with checking a backwards plan. What does the person want to work on? And we use that information to connect tasks with the visions and priorities they've identified as important to them. So backwards planning is meant to address as a whole how to build a care plan, but as far as how many people will be building the care plans, no one. Instead, this is really a tool for starting to work with patients. It's a physical tool to highlight patient priorities and to begin to discuss where the person wants to be. But what do I mean when I say that? Well, I'd like to share an image and a story with you. Next slide, please.
Bill,
So this is a picture of Michael, a previous patient of ours, and what we recognized a number of years ago was that there was a disconnect. Our care teams thought something was important and wanted to work on that, and the patient thought something else was important and they wanted to work on that. And we entered this tug-of-war scenario that many of us might be familiar with. So we stopped and we said, all right, Mike, write down every single thing that you would like us to help you with. No exceptions. It doesn't have to be medically based. Just write down everything you want us to work on. And if you look at what he wrote down, you'll notice that there are only two things that are medical. So this is really kind of our aha moment where we really saw where this tension's been coming from with our patients. that we've been really addressing their needs the wrong way. And so we started to ask all of our patients to do this. When we would sit down with them, we then compiled all their answers, and we really boiled down these to 14 distinct care planning domains that we could use to help identify what was important to work on and how we go about doing that. Next slide, please. So if we take a second to orient ourselves to the backwards planning board, we see that the left side of the board defines what participants feel they need to work on and what they don't. And if we look at the top of the board, that determines when they would like to work on something, now or later. By breaking these into quadrants, we see the upper left-hand square highlights what the person identifies as important to work on right now, and the lower right square is what doesn't need any work in the eyes of the patient. But this can be used to highlight their strengths and successes for all of the things that they've already completed prior to us working with them. The top right and the bottom left really create opportunities for discussion and help us to get to know the person's motivations and thoughts better. Why does somebody want to work on this later? Why does somebody feel that this isn't something they need to address right now? That really creates an opportunity for robust discussions, and it's been a useful tool. Next slide, please. So when we're looking at a sample backwards planning board, we see that domains include things like identification, have transportation, see if I qualify for insurance or other benefits, and maybe food and nutrition. There are many more, some that are socially based and some that are medically based. But when we connect the task with something bigger in their life, and so when I say something bigger, I mean something more than just staying out of the hospital, we start to ask, what is really important to you? Understanding these larger visions for their life can be really powerful, because when we're deep in the work and maybe struggling to get through the different goals we've set forth with them, we can start to tie the smaller tasks to the bigger picture for what they want for their life. So we can say, so why don't you remind me why you wanted to get a job? You know, I know it wasn't just because of money. This is really just a way to help motivate people in difficult times and figure out why they want to do these things. And what was really interesting was when we started to look at these wants or goals with the domains, we noticed something. Next slide, please. We found that there were three common themes that came up repeatedly when we talked to our participants. Basically, what our patients wanted were, first, significance. Really, the deep desire to feel important and recognized, to feel like you're contributing to society in some way. They wanted a sense of love and belonging, the deep desire to feel loved and cared for. And they also wanted certainty and safety, the deep desire to have controlled surroundings. It's about having a plan and knowing what is coming next in your life. So we show these as test tubes that can be full or empty. These test tubes aren't really meant to categorize people in an absolute sense. They're not meant to label and judge people, but instead they give us some common language and a way to kind of start to think about how we can best help our patients stay healthy. And these aren't simple test tubes that impact our patients. We've all had experience moments where we may have felt low on significance or love and belonging or certainty and safety. Really, for us to be therapeutic with the patient and to show true empathy, we have to consider that time in our own life when we've also been low in that test tube that our patient's going through. But doing so requires us to go to a place of incredible vulnerability, which can really be a good thing because it allows us to connect with other people, but it can be painful for us also. And, you know, so what's going on currently in my life or may have occurred in the past, that period of vulnerability may be too painful. And if that's the case, it may be really difficult to help our patients if we're both identifying as being low in the same test tube. It's okay to have those triggering events, but we just need to be aware of what is going on with our test tubes as well as the patients for us to give the best care possible. Next slide. So after we connect task to vision using the backwards plan, we move on to observing on normal routine. We had to figure an idea that, if somebody wanted help, we need to figure out how best to accomplish those tasks. And while observing somebody's normal routine is a simple idea, it's much harder to implement in practice. Next slide. The idea is that before we step in and try to fix a problem, before we look for a solution in our own way, we really need to step back and we need to ask questions. And this can be really powerful. What stood out to me when I started working in Camden and working at the Coalition is that our patients are incredibly resilient, they're very resourceful, and they've been managing their health and social needs well before I or our organization came into the picture. Next slide, please. Now, that doesn't always mean that they were doing so in a healthy way, but I think it's important to note that our patients all have systems in place. They all have ways of doing things that they're already comfortable with. So stepping back allows us to find out what has worked for them in the past so that we can ultimately build on what they already do well and what they could maybe use improvement upon. By guiding the person through problem solving, we're helping them build capacity to maintain these new systems once we're gone. They're finding new ways to solve problems instead of us having to solve problems for them or with them. Next slide, please. So how do we help someone build capacity to solve problems on their own? Since the primary focus of our intervention is to set patients up with the knowledge, tools, or skills so that they can manage their own health needs when we're no longer in the picture, we had to figure out how to get them to that point. And not to simplify the patient-provider relationship, but we recognize that the process is actually not that different from coaching somebody in any given sport. Next slide, please. So we'll use soccer as an example. Let's say that you want to learn how to do a new move. What do? Well, first you watch your coach. Your coach demonstrates the activity. You watch to learn what the coach is doing, and you take that in during that process. Second, you practice that activity, and you do so still under the guidance of your coach, so they can show you what you're doing well and maybe what you need improvement on. Lastly, if you practice enough, well, sometimes for a short period of time, sometimes for a long period of time, you develop the ability to perform the skill on your own. So we look at our patients' routines, what is working for them, what isn't, and then we assume a coaching style. Is the patient at an I do, where I need to model the skill, let the patient watch so that they understand how they can accomplish this? Are we at a we do, where we do the skill together while filling in some gaps if the patient gets stuck? Or have we moved to a you do, which really allows the patient to lead on problem solving and completing the skill? And we're there just really providing support and acknowledging their strengths. By tailoring our coaching style, we can help patients develop long-term problem solving skills. Next slide, please. Lastly, we move on to highlighting the person's progress with data. Next slide, please. So let's think about a situation that we're all familiar with, whether it's personal or from what you see maybe online or on TV. When people want to get in shape, when they want to lose weight, what are some of the things they do? Well, you often see people have a before and an after picture, and a lot of times maybe pictures in between. Why are they doing this? Well, apart from wanting to kind of maybe show off to their family and friends, they really want tangible evidence of the progress that they're making, because the evidence will motivate them to continue reaching their goal. And we can apply the same mindset to our patients. During our intervention, we can review the backward plan as needed and adjust it as needed to meet changing circumstances. And before graduation, we can review all of the goals we had set in the beginning, discuss what's been completed, and what's left to work on. This is the way to actually show somebody what they've done and what they're capable of accomplishing, that they can actually do this on their own. So by kind of accepting those we work with for who they are, helping them make plans based on where they are, and developing a vision based on where they want to be, we can build therapeutic relationships that help our patients with complex needs accomplish their goals while also accomplishing ours. And that is it for me. Thank you.
Great. Thank you so much, Bill. And thank you to Dr. Herbert, John, and Amy as well for your presentations. And I want to thank you to all the participants here for bearing with us through some of these technical issues that we've been experiencing. We apologize for that. I think we've had a lot of interest in this topic, and we've apparently broken the system. We do have the slides available for downloading on our Resources for Integrated Care website. So I encourage you all to go on there and download the slides, and we'll have the audio recording and replay of this available shortly after the webinar. And at this time, if you have any questions for our speakers, please submit them using the chat feature on the lower left of the presentation. You can go ahead and type in your comment and submit it, and we'll go ahead and proceed with the Q&A portion of this webinar. And I did see some questions come through earlier, so I'll go ahead and address those. Someone had asked about getting a certificate of attendance. So with this, we are not offering CEUs for this webinar, but if you would like a certificate for attending today's webinar, you can go ahead and email Rick, that's R-I-C, at lewin.com. That's R-I-C at L-E-W-I-N.com, and we can send your certificate for attendance. We did have a question for John. And John, are you still on the phone?
I am, although I've been disconnected again.
I'm sorry about that, the webinar. So we had a question about admissions by DRGs. I believe there was a slide in your presentation with psychosis being the top DRG. It seems like that data was from 2011 to 2012, and one of our audience members was just wondering, are those patterns still the same?
Yes, they are.
Okay, great. And I have a question for all presenters. So if Dr. Herbert, John, Amy, and Bill, if you want to go ahead and chime in cases where individuals have mental health and co-occurring substance abuse or substance use disorders, do you use different tools and strategies for each condition? Or can you apply same tools and strategies for both?
It's John. I think our general approach would be to apply the same techniques and strategies to both. Understanding each person is different, but the same ideas, I think, work pretty broadly.
Mm-hmm.
This is Barbara Herbert. I think that's actually a really complex question. We know that there's data for people who have alcohol use disorder and depression, that if you treat their depression while you're treating their alcohol use disorder, they have a better outcome of being able to get into recovery. But I think the intersections are actually quite complex. In my individual care, I often talk to patients who have substance use disorders as using the metaphor that part of their brain has been hijacked. If part of their brain also they see as not working because of underlying mental health issues. I think this is very complicated for people to absorb. And so I think we need to be distinctive in what we're doing, and to use tools wherever we can. But in Massachusetts, many of the overdoses that we're seeing now include non-opioid substances. Of course, they include benzodiazepines as well, many of the fatal overdoses. But we're also seeing fatal overdoses that include things like Adderall or atypical antipsychotic medication. So, of course, substance use disorder is about the person, not about the substance. But I think we have to be, that it's much more complicated to negotiate this terrain than we'd like it to be. And I feel like the person who raised that question probably has that experience.
Great, thank you so much. And here's a question for Bill. Just curious as to how some of your clients react to the backwards planning board, and how receptive they are to this idea.
I would say most of our patients really appreciate it because we're not focused on, hey, you need to stay out of the hospital, we need to keep you out of the emergency room. What we're really asking on them is what's really important right now, and so we're listening to them. And oftentimes we find that our patients feel like they're not necessarily being listened to, that they're being talked at and directed to do certain things without really understanding, their full complexity, the environment that they live in, the situations that may be occurring in their life. And so the backwards plan allows them really to kind of bring up certain topics that other people may not be asking about. If somebody needs to get to a doctor's appointment but they don't have transportation, are people just saying you really need to go to your primary care physician without asking do they have a way to get there, and then taking that second step to not just ask do they have a way to get there, but maybe ask how, talk to me about that. How do you normally get there? And so that backward planning allows them really to tell their story, and gives us a great chance to kind of see where are some of their challenges, but also to kind of highlight some of their successes, their resiliency, to create that relationship bond of, hey, I see you're struggling, but maybe you're not giving yourself enough credit as well. This is what you do really, really well, and I think you can use that in other areas that you want to work on.
Great, thank you so much. And one last question, I think motivational interviewing, that was mentioned across a couple of the presentations we heard today. Do any of you have articles utilizing the strategy for those in the audience, kind of reference or tools that you would recommend that others use if they were interested in starting to use motivational interviewing with their clients or patients?
Well, of course, the expert tools, screening, brief intervention, and referral to treatment that are widely available, I think provide a good framework for being able to ask, particularly about alcohol use disorder. But to some degree, they really set us up to be able to create a model for motivational interviewing. And that's capital S, capital B, capital I, capital R, capital T. There's a strong federal support for that.
Thank you, Dr. Herbert. And if folks on the phone have additional questions or comments, please go ahead and email them to ric@lewin.com. And again, the slides for today's presentation, the recording and transcript will be available on our website shortly. A huge thank you to all our speakers. This was very informative. And thank you to all our participants for attending and participating, and really your patience with the technical difficulties we're experiencing. So at the end of the webinar, a post-conference survey will appear in the window behind this web presentation. Take a few minutes. Your feedback is important to us, so please submit your survey. A survey will be emailed to you within 24 hours if you don't complete it at this time. Thank you very much, everyone. This concludes our webinar. Happy Friday. Bye-bye.